Anterior cruciate tears and patellofemoral pain syndrome are the most common complaints and serious injuries to the knee in athletes and active individuals. Improving strength and function of the muscles surrounding the knee has been the primary therapeutic intervention. The influence of the hip muscles on knee function has been documented during rehabilitation of cruciate and patellofemoral injuries. Hip muscles located deep in the pelvis direct rotation within the knee joint during walking and upright functional activities. These muscles are especially important during sports like soccer and basketball. Deep hip muscle control of knee joint rotation is essential for healthy lower extremity function without injury. At the knee, the femoral condyles articulate with the tibial plateau and meniscus. The knee capsule encloses the tibiofemoral joints and the patellofemoral joint. The knee capsule is reinforced by ligaments, fascia, and muscles. The patella reinforces the anterior capsule. It is attached to the tibia by the strong patellar ligament and is connected to the femur via the quadriceps muscles. The hamstrings reinforce the posterior knee capsule with their attachments on the proximal tibia and fibula. The lateral capsule is reinforced by the iliotibial band and semimembranosus. The medial capsule is reinforced by the sartorius, gracilis, and semitendinosus. Within the knee capsule, the anterior and posterior cruciates reinforce central rotational movement and anterior-posterior shear. The anterior cruciate ligament runs from the intercondylar area of the tibia in an oblique direction posterior to the medial aspect of the lateral femoral condyle. The posterior cruciate runs in a vertical direction from the posterior intercondylar area of the tibia to the media condyle of the femur. The anterior cruciate ligament limits external rotation of the femur on the tibia when the foot is planted. It simultaneously limits posterior shear on the femur on the tibia when the foot is planted. It limits full knee hyperextension and extremes of valgus and varus. The posterior cruciate ligament limits inward rotation of the femur on the tibia when the foot is planted. It simultaneously limits anterior shear of the femur on the tibia when the foot is planted. It limits extremes of valgus and varus. Gluteals, hamstrings, popliteus, quadriceps. Stability and control at the knee requires interaction of forces produced by muscles and ligaments around the knee and hip. Interaction is especially important for movement control in the horizontal and frontal planes. The gluteal muscles attach around the hip joint and outwardly rotate the hip through its full range of motion. They secondarily affect knee rotation since it's a midline motion and more posteriorly based. The hamstring and popliteus muscles are the primary muscles running across the knee joint posteriorly and that affect its rotation. The hamstrings function to flex the knee and secondarily rotate the femur on the tibia. The popliteus is an important internal rotator and flexor of the knee. It unlocks the knee during standing when the knee goes from extension to a flexed position. The quadriceps attach proximately on the femur and distally to the patella and function to extend the knee. During knee extension with the foot planted, the patella is stabilized on the tibia by the patellar tendon as the femur extends and rotates in relation to the patella. The adductors, sartorius, and gracilis inwardly rotate and adduct the hip from full outward rotation to midline. Secondarily, they direct rotation action at the knee. An important and deeper layer of hip-pelvic musculature directs tension through the cruciates that creates knee rotation and dynamic stability at the knee. When in functional balance, this muscle system alternates anterior and posterior cruciate tension during upright activities. This group of muscles is called the pelvic rotator cuff. The muscles in the pelvic rotator cuff system include the obturator internus, obturator externus, superior and inferior gemelli, quadratus femoris, adductor brevis, pelvic and urogenital diaphragms, and external sphincters. The short hip external rotator muscles are ideally designed to produce an effective mid-range external rotation torque at the hip and knee. The adductor muscles, especially the adductor brevis, produce mid-range internal rotation at the hip and knee. The pelvic rotator cuff dynamically rotates and stabilizes the hip while spinning the femur and knee through alternating mid-range internal and external rotation during every weight-bearing step. Force transfer down the femur creates midline rotation action at the knee around the cruciate tethers. This alternating midline rotation is essential for knee stability and force transfer between the hip, knee, and ankle. Anterior cruciate injury occurs with extreme external rotation and posterior translation of the femur on the tibia with the foot planted. In conjunction with a valgus force, the anterior cruciate is even more inclined to tear. In many cases, it is a combination of factors that leads to internal tibial rotation torque at high velocity while the ligament is under tension. Frequently, anterior cruciate tears when the foot is planted and the athlete is cutting and turning to an opposite side. This is a sudden and uncompensated shear in rotational force at the knee without an effective counteraction in all three scenarios. A strong and balanced pelvic rotator cuff muscle system is designed to maintain the knee in rotational balance and prevent cruciate injury. Imbalanced mid-range outward and inward hip rotation changes knee rotation and patellar tracking. Patellofemoral pain syndrome is typically described during weight-bearing activities that use hip musculature to control knee motion. Previously, it was thought that the patella was laterally tracking improperly on the femur, but the latest research shows that femur rotation may be the primary consideration. This midline rotation deviation of the femur can occur when there is weakness or imbalanced action of the deep rotators of the pelvic rotator cuff. Significant weakness of hip lateral rotators and excessive internal rotation and adduction at the hip are significant in women with patellofemoral pain syndrome. Midline, mid-range hip rotation exercises can rebalance the dynamic knee spin to align patellofemoral function and normalize torque transfer through the anterior-posterior cruciate ligaments during walking, running, jumping, and pivoting. This is deep, dynamic postural muscle work at the hip having to do with rotation in weight-bearing. Balanced midline, mid-range pivots in weight-bearing is the key to healthy knee function. The therapeutic progression begins in supine, progressing to sitting and standing.